Okay, good morning, everyone. Today the topic which I'm going to take the classes on endodontic periodontic interrelationship. This is a very important topic in the clinical perspective as well as for your exam point of view. This endodontic periodontic relation, since the tooth, the pulp, and the periodontium, all three together work as a biological unit. Any disease of the pulp can progress onto the periodontal space, onto the gingiva, onto the affect the tooth support, the bone support of the tooth. In the same way, any periodontal problem in the mouth can progress and affect the pulp of the tooth and can communicate into an endodontic periodontic lesion. Now, the clinical aspect of this endoperiod lesion, it is very common clinical finding in the patient. So to identify a periodontal lesion and differentiate it from an endodontic lesion is very important. And you should also know when it is showing a combined clinical symptoms. So in the same way, as an exam point of view, you are likely to get at least a short note on this topic. So it is very important that you should understand this topic well. You can get a short note or even an essay question from this topic, both in conservative endodontic paper as well as your periodontics subject. Now, coming to this relation, the relation between the periodontal and the pulpal disease was first described by Simmering and Goldberg in 1969. Later on, the term pulpodontic periodontic syndrome was described by Bender and Seltzer in 1972, and now it is still the thing. The terminology has changed slightly. It has become the endoperiodontic endodontic periodontic interrelation, but still a lot of treatment aspects have improved since 1972. Now, coming to the pathways of communication between the pulp and the periodontium, you have different pathways which are developmental, pathological, and iatrogenic. In developmental pathway, as you all know, the apical foramen is the main path of entry and exit of the tooth. The pulp communicates with the pulp through the main entry, that is the apical foramen. Any infection, any microorganism, any exudate collected in the pus, as in the form of pus, and all that can communicate from the pulp through the apical foramen to the periodontal space, or vice versa, same way from the periodontal space to the pulp. That is the most common developmental communication between the pulp and periodontium. Second, you have the accessory canals or the lateral canals, which are the accessory communications between the pulp. They're canals which separate from the main canal in 90 degree and communicate with the periodontal space. Then apart from that, you have congenital absence as a developmental defect. Sometimes there is congenitally absence of cementum, which on the root surface or in the cemento-enamel junction. So when there is absence of cementum, the dentinal tubules can communicate directly from the pulp into the periodontal space. Still, further, some developmental defects or developmental groups, deep developmental grooves, for example, the palato-gingival groove, all these can have a communication between the periodontium to the pulp or create a perio problem communicating through the apical foramen to the pulp. And also you have enamel projections or enamel malformed enamel or malformed tooth structure, which can create a periodontal problem, which can later on communicate to the pulp. Now, apart from the developmental developmental communications, you have the pathological communications. In pathological communications, you have the vertical tooth fracture. When you have a traumatized tooth, or when you have an endodontically treated tooth, which causes fracture of the tooth, this fracture can communicate from the pulp space to the external tooth surface. Same way, when there is a traumatic injury to the tooth, or when there is idiopathic resorption on the root surface, it can be internal resorption as well as external resorption. It can be due to any iatrogenic reasons, which we'll come to later. All these resorptive defects can extend and progress to an extent that they communicate with the external or the internal tooth surface. Similarly, you have loss of cementum due to external irritants. Any external irritating factors can cause the cementum getting disturbed, and that also can create the communication, as I told you earlier, through the dentinal tubules. Then you have the iatrogenic factors. These are the exposure of the dental tubules during root planing. When you do a periodontal treatment, or when you're doing the root planing of the tooth, you're iatrogenically removing the cemental surface of the tooth, creating this communication. There can be accidental perforation of the tooth during endodontic treatment. While doing endodontic treatment, if accidentally you perforate the tooth surface in the furcation area or in the lateral tooth surface, or while doing your lateral perforation, while doing your biomechanical preparation or the cleaning and shaping of the tooth, you can create a lateral perforation to the external tooth surface. And also during endodontic treatment, as I told you earlier, when you use excessive pressure or excessive condensation pressure of gutta bacha, or you excessively thin the root surface later on occlusal chewing or loading, there is root fracture, which can create a communication. All these are the possible ways by which the communication can happen from the pulp to the periodontium, and periodontium to the pulp. Now, these are just to show you the SEM picture of apical foramen and lateral canals. With apical foramen is a major pathway of communication between the pulp, and you can also see the lateral canal, which can also communicate from the pulp to the external tooth surface. This is the radiograph showing the obturated tooth, but clearly you can see few lateral canals on the lateral surface of the root, which were the possible venue for communication between the pulp and the periodontium. So this periodontal defect, after the root canal has been treated with the cleaning and shaping of these lateral canals, healing must have occurred. So it is very important to obturate or clean the lateral canals so that the communication between the pulp space and the external periodontium is sealed well. This is the SEM micrograph showing the dentinal tubules, which are also a possible venue for communication. And here you have the pathological communication, the external tooth resorption, internal tooth resorption, which communicate between the pulp and the external tooth surface. Now, as we told all the possible venues, the etiopathogenesis of endoperio lesion, you have the you have the etiological factors like live pathogens, bacteria, fungus, virus, and foreign bodies like calculus or plaque, oral hygiene, cholesterol crystals. All these are the possible etiological factors which can aid or help in the communication between the endoperio lesion. Now, all these three etiologic factors, then anatomical consideration, as I told you, the dentinal tubules, lateral canals, and apical foramen. These are the normal anatomical considerations. And other contributing factors are the poor oral hygiene, poor endodontic treatment, poor restoration, trauma, resorption. All these are the contributing factors, and all three together one or two of them, they can help in or aid in the progression of the endo-perio communication. Now, coming to the clinical diagnostic procedure, first and foremost, a detailed dental history or a detailed case history is very necessary to have proper diagnosis of this endo-perio condition. So when you take a dental history, you should the patient will communicate to you what was his chief complaint. Then you should take a detailed exam, a detailed question on the history of his present illness. How old was this condition, or how old was his symptoms? Because that is very important in identifying whether it is a periodontal issue or whether it's a pulpal issue. So that his dental history plays a very vital role in diagnosing the condition. Similarly, visual examination of the oral cavity, the surrounding supporting soft tissue and hard tissue, palpation, percussion, mobility, probing, all that should be done, because for a periodontal issue will have a little different set of clinical symptoms. Same way, if there's any fistula on the oral cavity, tracing the cavity and taking a radiograph to identify the tooth in question from where the source of infection is. And same way, the vitality test is very important in diagnosing an endo-perio lesion. So we'll come to all this in detail. Now, for the classification of endo-perio lesion, you have the Simon's classification, which is very easy to remember and very simple classification. It is based on the etiology and subsequent progress of the disease. Now, in this classification, you have a set of 5 different conditions. One is the primary endodontic lesion. This is the common endodontic condition. It is just the endodontic lesion alone. In the second one, you have the primary endodontic lesion with secondary periodontal involvement. Here, the primary reason for the condition is the endodontic or the pulpal problem, which has progressed and involved the periodontal space and is showing symptoms in the periodontium. So here the treatment will be slightly different. You'll have to modify your treatment because it's not an endodontic lesion alone. It has a secondary periodontal involvement. Now, third one is primary periodontal condition. In primary periodontal condition, it does not involve the pulp, but you should be able to differentiate why the pulp is not involved. So you don't have to do any pulpal treatment. You'll have to treat only the periodontal condition. But if this condition is not identified and left alone, it can progress into a endodontic disease. So identifying this condition at an early stage and doing your treatment is very important, both in primary endodontic lesion and primary and periodontal lesion. Then fourth, you have the primary periodontal lesion with secondary endodontic involvement. In primary periodontal lesion, it has extended or progressed into a stage where the the pulp portion of the tooth has been involved. So you should be able to differentiate that there is a pulpal involvement, and which is a tooth which is involved in with the pulp, and then you'll have to do the treatment accordingly. But you'll have to treat both the periodontal and the endodontic condition. And you have another set which is a true combined. So you have both periodontal as well as endodontic problems beginning at the same time, beginning almost together, and then later on they progressed and reached a stage where they have a communication. Here also your treatment should be a combined treatment for both endodontic and periodontal. Now, coming to the primary endodontic. Before that, let us just have a look into what are the clinical signs and symptoms for a endodontic and what are the clinical signs or symptoms in a periodontal condition. Here in a endodontic condition, the etiology, usually the pulp has become necrotic or pulp has entered a stage of irreversible pulpitis. So in this condition, the pulp is usually irreversible or necrotized. In that condition, the endodontic treatment is a must. In the periodontal condition, usually the etiology is this inflammation or infection in the periodontium. That it could be due to different factors, but there is a periodontal inflammation or infection which has to be treated, identified and treated. Second is in endodontic condition, pain is usually acute, excruciating, and spontaneous in nature. So, endodontic problem, the pain is little severe, sharp shooting pain. You may have night pains, postural pains, all that you find it in endodontic condition. But in periodontal condition, you don't have a severe pain. It is usually dull and it is dull chronic. So it's not a very severe condition, but still, if you don't identify or treat it, the patient usually don't identify this at an early stage. So this dull chronic pain, they leave it till it reaches the pulpal pain, or when it reaches a severe stage, which cannot be treated by periodontal treatment alone. Next, you have swelling in endodontic. The thing only when the infection has reached the periapical area results in an abscess, there is swelling. Otherwise, the swelling is inside the pulp chamber, and that is it has a very severe because the swelling or the inflammation of the pulp is in the pulp cavity. So the pain is very severe, and a patient will not be able to tolerate the pain and all. But in a periodontal condition, there is swelling in the localized to that area, or in the tooth area. There is gingival swelling, and the pain is not that severe. Percussion in endodontic condition, the tooth, when you percuss it, there is pain when you percuss the tooth in the vertical direction, because there is periapical inflammation of the tissue. So when you percuss the tooth in the vertical direction, usually the patient has pain. But periodontal, usually the pain is mild, but you have pain when you percuss it on the lateral direction, because there is bone involved. There's a bone defect. So when you percuss the tooth in the lateral direction, you may find a mild amount of mobility increased and pain when you percuss it on the lateral direction. Same way, probing, usually in endodontic conditions, you don't find much of probing depth. Normal sulcus depth, other than that, the maximum 3 millimeters of sulcus depth is normal. But in periodontal condition, you find a pocket depth of more than 3 millimeter. In endodontic, the pocket depth is not much affected, not at all affected. Then next is the sinus tracing. Gattapacha points, if you it leads to, if there's a sinus tract on the tooth, if you place a Gattapacha point there, it will lead to the tooth in question. But in a periodontal condition, you won't usually find a sinus tract which leads to the tooth apex. Then mobility is usually rare or localized in endodontic condition, but in periodontal condition you find more mobility, or it's usually generalized, not a single tooth alone, multiple tooth are involved. Usually a periodontal problem commonly do not affect a single tooth alone. So when multiple tooth periodontal problem usually affect multiple tooth of a few teeth in the same arch, or the total upper and lower arch together. So periodontal the conditions are usually generalized. Endodontic are usually localized to a single or one or two teeth. Then on a radiograph, the junction epithelium appears normal in endodontic condition. In periodontal condition, there is apical migration of the junctional epithelium. Same way, gingiva is normal in endodontic condition. There is inflammation and recession of gingiva when there is a periodontal condition. Usually in endodontic treatment, there is the therapy usually is root canal treatment or endodontic treatment of the tooth. You don't have to do periodontal treatment unless there is a secondary involvement. And in periodontal condition, usually period treatment alone is required unless it has progressed into the pulse space, which requires endodontic treatment. Now, I just want to tell you the common clinical signs and symptoms. Now coming to the classification, I told you, Simon's classification. You have any other classifications also, which are also used according to the treatment plan and all that. But Simon's classification, as an undergraduate, I think this classification is more than enough, and it's very easy to remember also. Now coming to primary endodontic lesion. Usually a primary endodontic lesion is it happens due to caries or deep restoration or a traumatic injury. These are the common causes for a primary endodontic condition. It can be a caries which has not been treated and progressed into the pulp, and which has transferred the microorganism into the pulp, creating a irreversible pulpitis. So, or it can be a deep restoration, the restorative material, or when there's secondary caries around the restoration, or when there is a restoration without an adequate base, or when there's a restoration which has irritated the pulp, causing an endodontic problem. And another one is the traumatic injury, a trauma to the tooth, which has caused concussion or severe apical blood entry to the pulp space, which has seized the pulp entry or the inflammation into the pulp and caused an endodontic condition. Now, all these, whatever the cause is, the clinical features are usually pain, tender on percussion, swelling in the marginal gingiva, and periodontal abscess can happen. Now, the treatment here, as you all know, is endodontic therapy of the tooth involved. Here, periodontal treatment is not at all required because it's only an endodontic condition. Your proper diagnosis is very important so that you identify it is endodontic condition. It hasn't progressed into the periodontal space. It hasn't caused any secondary perio condition. So here, your treatment is just focused on your pulpal condition. That is, you remove the diseased pulp, you clean and shape the canal adequately, and obturate it with a three-dimensional obturation so that the remaining apical tissue heals to itself, and you give a post-endodontic restoration. That is all for your primary endodontic condition. Now, the second condition is primary endodontic lesion with secondary periodontal involvement. Here, a long-standing endodontic lesion, if it's not treated with, will lead to destruction of the periapical alveolar bone. This destruction progresses into the interradicular area, creating the breakdown of surrounding hard and soft tissue. Now, here I told you, if the patient has this primary endodontic condition and it is not treated at the right time, this microorganisms from the pulp space progress through the apical foramen into the periodontal space. It can remain like that as a chronic periapical inflammation, and later on cause destruction of the bone around the apical area and form a periodontal condition. Here, the patient may have the endodontic pain. Okay. Then apart from that, there may be a pocket, periodontal pocket, but usually this periodontal pocket is localized to this tooth alone. That is another identifying factor. There's a periodontal pocket around the tooth involving a single tooth. There's a caries lesion on the tooth, and you history of pain, or there is vertical percussion pain, you can suspect there was a primary endodontic lesion which has progressed and reached the periodontal space, creating an endoperio communication, creating endoperio and having a secondary periodontal involvement. Here the treatment is endodontic treatment followed by periodontal management if required. Now, usually if it is very mild, it has just progressed into the apical area, you do endodontic treatment and evaluate the periodontal condition. That healing will occur by itself. Prognosis depends on the severity of the periodontal involvement. If the periodontal condition is not resolving, then only you have to go for your periodontal treatment. Usually when you do an endodontic treatment and clean the pulse space, remove all the microorganisms, adequately obturate the pulse space, the periodontal condition will return to its normal state. So the treatment, depending on the severity of the periodontal condition, you can go ahead with the perio. Otherwise, just do an endodontic treatment and evaluate the periodontal condition. Now, in a primary endodontic disease with secondary perio, this X-ray you can see the pulp has the tooth has a large restoration or a crown over it. There is a periapical lesion around the apex of the distal root. This periapical lesion has progressed and into clinical periodontal abscess on the buccal side of the tooth. So when you probe it, you find localized pocket on the buccal surface. If you place gutta-percha in that and track it, it can point you to the apex of the tooth, showing you that this was the communication between the root apex to the periodontium. So when you identify this, check the vitality. Vitality here is very important. You check the vitality of the tooth. Most probably the tooth is non-vital. Most probably, if the tooth happens to be non-vital, it is a primary endodontic condition. If the tooth is vital, then you should suspect some other reason for this periodontal illness. So vitality check is also very important in this condition. Next, here you have another primary endo with secondary perio. Endodontic treatment is done here. Post-operative healing is happening. Here they have done a endodontic treatment of the tooth, and you can see the bone forming around the root apex. So it's showing secondary healing after doing just the endodontic treatment alone and evaluating the case. Now the third condition, as I told you, is the primary periodontal lesion. In primary periodontal lesion, the main causes are usually plaque, calculus, poor oral hygiene. The patient is there's a lot of deposits or stains around the tooth, which has caused gingival inflammation. And also you find traumatic occlusion sometimes, a traumatic occlusion which has caused localized periodontal defect. So traumatic occlusion could be a high restoration or high crown which has been placed on the tooth. So here the clinical feature is a broad-based pocket formation. So when you check the tooth is usually, you find a pocket which has a broad base, but a wide open pocket which is narrowing down. There's mild mobility of the tooth. There's widespread bone loss around the tooth, and patient usually has generalized periodontal defect unless it is from trauma from occlusion, which is localized. The plaque or calculus around the tooth can create a generalized plaque calculus usually has generalized the thing. It is, you find multiple teeth involved. Once you identify that, your treatment is usually a periodontal treatment. Prognosis depends upon the extent of the periodontitis and a patient's ability to compile with the potential long-term treatment and maintenance. So here you just normally you treat the periodontial, that is you do oral hygiene treatment, like oral prophylaxis, give medicines for the sake to maintain the oral hygiene, then remove the trauma from occlusion if trauma from occlusion is the condition, and then evaluate the periodontal condition for a period. You don't have to do endodontic treatment here, because this is the importance where you differentiate the primary condition and the secondary condition. So your treatment shouldn't be to devitalize a tooth. So do your periodontal treatment only if you are confirmed that the pulp of the tooth is involved. You go ahead with the you should do an endodontic treatment. Otherwise, just a periodontal treatment alone will do that will suffice, and repair will happen.